Okay, I see us getting right about at noon by my clock, so we'll get started. Welcome everybody today to our geriatric echo on effective communication with older adults. And we have Jessica Foley from our speech and language, your communication disorders program? Is that what it is?
Yep.
Yeah.
Communication sciences and disorders. Yeah.
Yes, communication sciences and disorders here at UND. So she will be kicking it off for us. Just a few housekeeping issues. I'm going to go ahead and launch a poll for you, the pre-test poll. Go ahead and take the pre-test if you can. I will tell you though, don't panic if for some reason you don't get a chance to answer the pre-test. We do like having it up there, and we do compare the results to see change in knowledge. But it's not up for forever. So if you don't get a chance, it's okay. It's not tied to your ability to get CEUs. But please go ahead and take a chance to answer that poll. And then after you answer the poll, take a moment to put your name and whatever, organization you're with into the chat. We do like it if you can leave your cameras on to just kind of help with the camaraderie and us feeling like this is engagement. But I also understand for various reasons people are unable to. It's also over lunch hour, things like that. So if you are able to, please do that. I will be monitoring the chat as we go on throughout the session. So if you have a question, you are welcome to raise your hand, or you are welcome to type it into the chat, and then I will find kind of an appropriate time to ask the question during the session. We also will have some time, hopefully, for question and answer towards the end. And Jessica also has some scenarios for us towards the end, so that as well. So please, and so with that, I am going to end the poll and share the results, and I am going to turn it over to Jessica for her session. Thank you very much.
Hey, welcome everybody. This is my first Project Echo professional development. I've never attended one myself, and didn't know about it before I was invited to speak. So I'm glad to be with all of you here today. Get my screens right here. There we go. So just a quick introduction. So like she said, my name is Jessica, and I'm a speech language pathologist. I teach here at UND in the Communication Sciences and Disorders program. So I teach undergraduates who are training to be either speech language pathologists or to go on for their doctorate in audiology. And if you have any questions about our program here or anything like that, I put my email on the first slide. I'm glad to communicate and connect and network and answer any questions that you might have. Today's presentation is mainly going to be focusing on the areas of communication that you see there listed in the bulletin points. We are going to focus on some changes that you'll notice in your patients as they're aging. Sometimes just the normal aging process, but also when we have degenerative or medical conditions that can affect our communication changes as well. So we'll talk about that. And then we'll also talk about some strategies to maximize our communication, whether our communication changes are due to normal aging or some type of disease process. So our learning objectives today are, first of all, to understand what domains of communication may be affected by aging, and to differentiate among what you might see that's typical as all of us get older, or things that might be concerning changes and something that might need a referral to possibly an SLP or an ENT or a neurologist for a consult. And then embedded throughout, we'll talk about strategies to communicate more effectively with elders, whether it's due to normal aging or not. And these strategies really can be good for everybody too, all the people that we communicate with in our practices. So I'll start by briefly highlighting why good communication is so important in service delivery for our patients. So when we think about communication, communicating with your patients and your clients, we really want to strengthen that patient and provider relationship because that increases adherence to our recommendations. So when we have that therapeutic partnership, that's going to lead to better health outcomes for our clients. So think about if your patient thinks you aren't listening to them or you aren't explaining something well to them, that can be the end. You can get some shutdown there. So what we want to do is maximize our communication to create that good therapeutic partnership so that we have better health outcomes and better patient satisfaction when they come to see us. And then lastly, I also wanted to note that good communication is critical for reducing malpractice suits and medical errors. I'm one of the teachers of the interprofessional healthcare course here at UND, where we have students from OT, PT, speech, nursing, medicine, a few different mental health and social work professions. And we meet all together, and we spend a lot of that class talking about how can we communicate well with each other, how can we communicate well with our patients, and what we can do to reduce those miscommunications and medical practice errors. So overall, in general, we want to make the most of that limited interaction time that we have with our clients because communication is so important to all aspects of patient care. So let's talk first of all about what domains might be affected by aging. So as SLPs, we have what we call the big nine. We treat lots of different areas. They're not all listed on here. We're not going to go through all of those today. But I do want to start with a little bit about how vision can affect communication, because that's an area that people don't often think about, written language. We'll talk about hearing changes, voice changes, cognition and language we'll talk about together because those are really hard to separate. Language is a cognitive skill, right? But we do some treatments differently than we do for our cognitive clients and our language impaired clients. And we'll spend just a little bit of time talking about speech changes through the normal aging process. And the only time I'll talk about this during the presentation, I have to give a little plug for dysphagia. Do remember that SLPs also treat swallowing disorders, dysphagia, and we can notice some normal aging changes in swallowing as well. But if you're starting to notice weight loss, difficulties with food, pocketing, any type of coughing, choking, concerns with aspiration, sometimes aspiration can't be seen, it's invisible. But anytime you're questioning any of those types of things, do make sure that you do refer to an SLP. So I just wanted to put that in there, even though this presentation is about communication. When I think of aging, I think of dysphagia as well. We're big advocates of the free water protocol. Water is pH neutral. Water doesn't cause aspiration pneumonia, but germs in our mouth do. So good oral cares and free water protocol, that's what we advocate for our clients. So that could be an entire presentation all on its own. So let's start with the effects of vision changes on communication. So as people age, we know that our vision changes. I'm in my 40s and I'm noticing this already. As people age, their lens thickens and your iris can become more rigid. So they're not as flexible in making changes to different lighting conditions. That results in less light entering the eyes. So that can make it really hard to see in dim lighting. Or if you are sitting somewhere and you're backlit, like a big window behind you. I closed my blinds before this presentation because it was making the screen difficult to see. Same thing, think about the lighting conditions in your clinic. Think about the contrast and the readability of your signage. Are you using fancy fonts or using clear block letters? Good contrast between the font, not a lot of like pale colors or reds and yellows. Also make sure they're at eye level, even for people who are in wheelchairs. So we want to make sure our signs in our clinic spaces are at eye level. Some things that we can do is handheld magnifiers or little magnifying bars. Those are easy things we can keep in our offices. Think about the glare of lamination. Try to use matte, not glossy, if you have things that you are laying out for people to look at. And how about writing? Writing is part of communication too, written communication. So we can have large areas when we have blanks for people to respond or to sign, signature guides, good spacing so that we leave room. You can consider using something like a felt tip pen instead of a pen that has a really fine tip that may be difficult to see as people are writing. Make sure you always inquire if somebody has eyesight deficits, make sure they have their glasses on. And the last point, think about the readability of your websites and your online portals. So we'll talk more about accessibility when we're talking about health literacy later on in the presentation, but your contrast, your sizes, your fonts, that needs to be considered on our online portals as well. And I know more and more of us are using those. So. All right, let's move on to hearing, because hearing is a big one. So as we age, that normal aging process in our ears is called presbycusis. So the incidence and severity of our hearing losses increase significantly with age. So of those older than 60, over 25% have more than just a mild hearing loss, but have hearing loss that can affect them too, like a disabling hearing loss, we would call it. And so of those who could benefit from hearing aids, and there are almost 30 million Americans who could benefit from hearing aids, a very small percentage of those actually acquire their hearing aids and consistently use them. So we're all familiar with how often our hearing aids end up in the drawer, right? Of the adults 70 years and older with hearing loss, only about 30% are using them. And in younger adults, under 70 population, it's only about 15% are actually using the hearing aids. And those are, that's from those that could really benefit from them. One problem that we run into, hearing aids are not covered by Medicare yet. There's a lot of advocacy going on, but they're considered cosmetic devices. So folks can come in and get their hearing tested, and that can be covered, and you can get a diagnosis, and your hearing aids aren't covered, and they can be thousands of dollars. There are a lot of different makes and models. There's a large range of what's available and prices. AAA, American Audiological Association, and ASHA, American Speech Language Hearing Association. We're doing a lot of advocacy, but as of now, hearing aids are still not covered by Medicare. Now, some other insurances will cover hearing aids for children, and some will cover for adults as long as the hearing loss is not caused by the normal aging process. So imagine how this is going to affect your communication if you are not hearing. So this is why it's really important for us to think about. Now, if you've heard of the over-the-counter hearing aids that are new to the market, that's a big topic right now too. Those are more intended for mild to moderate hearing loss, so they can help. They can help a person, but you're not getting an audiologist with that when you go to Costco and buy your hearing aids. They're not being mapped and adjusted specifically to your hearing profile. They're not being troubleshooted. Troubleshot, is that the past tense of troubleshooting by an audiologist? So there are some concerns with that. I would definitely recommend that we would want to be seeing an audiologist, but for some people, we understand that cost is prohibitive. However, these over-the-counter aids sometimes are just expensive as ones that you can get from an actual audiologist who is a hearing aid dealer. So we recommend seeing an audiologist. So we know it's prevalent. We know that getting hearing aids can be hard. So what can we do about this? What are the effects? Untreated hearing loss can have significant effects for our elderly populations, but also for our people who are still in the workforce. People are working longer and longer these days, right? So think about how that impacts our vocational choices and our job performance. Adults with hearing loss are affected socially as well. Think about the feelings of isolation, poor self-image, feeling that they're left without that social connection. This can lead to depression, withdrawal, and when we're looking at our medical practices, those feelings can lead people to delay their routine medical attention and could lead to severe health complications and conditions. I think this is a really important point, that there is a very well-researched positive correlation between degree of hearing loss and risk of dementia. So if you're interested in reading about that, I did cite a good source on that. Basically, you're having a faster rate of brain atrophy if those sound signals are not getting in and being used in our brain. And the severity actually correlates the hearing loss with the levels of the different types of dementia. So we can have a lot of very significant effects of not treating hearing loss. So what strategies can we do when we have people coming into our office? First of all, make sure that they have their hearing aids on if they have them. Ask, are you having hearing difficulties? Check that out. Ask the listener, what's the best way that I can communicate with you? Definitely control the environment. Make sure they can see your face, good lighting, no backlighting. So if they're using facial expression cues and lip reading cues, something people need to be aware of is don't shout. That distorts the auditory signal and can actually make it worse. Louder isn't always clear. So that's something for you to remember. Speak slowly and clearly, but we don't want to use greatly exaggerated intonation and sing-songy voice. That doesn't really help. So slowly, clearly, louder. Use some strategies such as rephrasing, spelling things, gesturing, write it down, and do a comprehension check. Ask them to repeat back what they heard. We really do want to make sure, though, that we avoid that really sing-songy, like how you speak to babies. We call that parentese. We don't want to do elder speak that can be patronizing as well. So make sure that you're speaking slowly and loud and clear. A few more strategies. You can say numbers separately, 5, 6, if you're having them write something down instead of 56. You can use your alphabet cues like we do on the phone. A lot of times, M as in Mary, B as in boy. Another good strategy, just like the comprehension checks, is let them know if you're changing the subject. Are there any other questions on this before we move on to this? That's that linguistic cue to cue them in that I'm going to be talking about something else now. That can really help. And again, with the environment, limit your background noise. Fans, music in the background, things like that can make listening very hard. And I don't know if any of you have a pocket talker. We have some of these in my clinic here that we use. It's a personal amplifier. They look like a little portable, like what we used to call a Walkman. The patient puts on the headset and you have a little mic pack that you talk into. We use those for our folks who either don't have hearing aids or forgot them, or they're being repaired, something like that. I think we just bought another one last week for about $120. So that's a good thing to keep on hand in your offices as well. Any questions about hearing? Okay. Let's move on to voice changes. So this is more about changes that you'll notice in the client versus things that you can do. So just like our hearing changes as we age, so do our voices. So think about what a voice sounds like for an elderly person versus a younger person, and we call that normal aging process presbyophonia. So this is affecting about 30% of adults over 50. So that's not even elderly, right? And here's where we can notice a decline in the range of your pitch. So your low to high, the pitch of your voice, that range kind of shortens up a little bit. You might have some pitch instability, so a little bit of a wavering quality in the voice. We might notice a muffled quality and lower intensity. So muffled and lower intensity meaning a little bit quieter. So think of dentition changes, when you're either losing dentition or transitioning to dentures, things like that. Some of the tissues in the back of our throat and our velum or a soft palate can become floppier and lose tone. And that's that soft palate, that velum is what prevents us from sounding hypernasal. Okay. So lots of changes in our cartilages and our tissues. Lower intensity, perhaps affected by breath support. Okay. Different lung capacities. And so quieter voice you might be hearing. In women, our pitch tends to lower, and in men, the pitch tends to raise a little bit. So become more toward the middle as we age. And some people don't like that. They might notice that. But what I want you to think about is the significant impact that this has on life participation, socially and vocationally. Our professional voice users are not just singers and actors and actresses, but teachers, professors, secretaries, announcers, people who are on the phone all of the time. If you are having laryngitis and losing your voice and not being understood, this can have a pretty significant impact on your job. Socially, same with hearing. People can become withdrawn, difficult to speak in crowds at social events. So if you're hearing some of these normal changes, what people don't know is that something can be done about this. You can refer to an SLP. We can provide training on and strategies for good vocal hygiene and also do VFEs. Those are vocal function exercises. There are some really good outcomes and improvements when individuals who need to use their voice for their vocation go through a course of treatment and learning VFEs and things that they can do at home. But what I want you all to know is if you are noticing pain, severe hoarseness that keeps coming back and not going away, loss of voice frequently versus more than just, I lost my voice after a cold and it came back, then we need to look for some possible pathologies. There could be polyps, nodules, edema, laryngeal cancer, growths, things like that, that you'd want to see SLP and ENT for. So just those are some things to keep in mind for the normal aging process with your voice and things to look out for. Again, that could be another topic all by itself too. So I'm going to move on to cognitive. And like I mentioned, we'll put cognitive and language together because they're really hard to separate. Language is a cognitive skill, and a lot of the strategies that we use for these are the same. So when I'm thinking of cognitive challenges on communication, I'm thinking about, as we age, our decreased working memory, our decreased sustained attention to task, and in general, any of those executive functioning domains, any of those executive functioning skills. As our cognition changes, that can affect the processing of complex sentence structures. So we'll talk about maybe what are some better sentence structures to use. But again, as always, if you're seeing significant changes in functioning, sudden onset, that's when we want to be seeing your physician, your SLP, your neurologist, so that we can determine is something going on there or not. So when we're having cognitive challenges, there are a lot of things that we can do to have better communication and better meetings and encounters with our clients and our patients. So I have several slides about this. Meet in a familiar surrounding or having a familiar person present. That is always something helpful. And do that frequent cueing to the environment and the activity, that reorientation, like explaining or re-explaining who you are and what you're doing. If you're doing some type of assessments or tests, you can help make it clear that this, isn't to test them, but it's we're searching for information to help them. That can be really helpful. A lot of times we're tempted to speak to the caregiver, and we really need to talk with the patient directly and not talk about them in third person. We don't want to underestimate patients' ability, even if they have dementia, to express opinions about their care. Some things we can do linguistically ask less complex questions. So yes or no answers might be helpful depending upon your topic. Watch for those nonverbal communications. You can tell by facial expressions, body language. Sometimes that can help cue you in to if a person is following along and understanding, or if they look confused or wandering their attention, that can cue you in that maybe you need to re-explain or use a different strategy. We like to stick to one topic at a time. So one question at a time, one instruction at a time. And this is a good strategy for, cognition and language. Provide your information through more than one channel. So you're saying something and write it down, or put something in a chart, draw a picture. If it seems like they're struggling for a word, assist them, see if you can help them, find that word. You can also consider doing follow-up calls with, instructions if you have outpatient instructions to ensure that they're understanding. Some more strategies. If the patient is able, or if they have a caregiver with, encourage them to take notes. And this is good for everybody. A lot's coming at us in these meetings, so we want to make sure we're taking notes. You can repeat your key points at the beginning, again at the end. Keep coming back to that. When you are doing visit summaries like this one, for example, with your written instructions, give detailed instructions that don't leave a lot of room for interpretation. So you can see some of these are very specific. Walk around the block every morning, walk around the block every afternoon. That makes more sense than, building more exercise. This is very specific. It's very concrete. So instead of saying, increase your fluids, you could say drink at least 1 6-ounce glass of water every 2 hours. And you can have a little chart to check things off, something like that. Assessing understanding, again, we call these comprehension checks with the teach back method. Okay, now you tell me, okay, what's the main issue? What do you need to do? And why is this important? So that's a good way to do a teach back at the end. Make sure that you give them a chance to ask questions as well. And I have a few more strategies. Think about your sentence complexity and the length of your sentences. You want to say the main clause first instead of embedding it in the sentence or putting it later. So it would be more clear to say, take your seat and you won't miss the movie, versus if you don't want to miss the movie, you should take your seat. Look what's mentioned first. You're talking about missing a movie. This isn't a medical example, but you could say something like, you could chunk something better instead of saying, you have arthritis of the hip, which makes it painful for you to walk and may eventually require hip replacement surgery if we can't control your pain with medications. That's really long. We had which, may eventually, if. Those are really hard when we have if, although since, before and after, those can be really tricky, before and after. So it'd be better to chunk that. You have arthritis. The arthritis is causing pain in your hip. Taking the medication should help. If the pain continues, we'll consider surgery. So it's in order, chunked into smaller phrases. That's really going to increase your comprehension. So we want to say the main clause first so that we're not taxing our working memory, and chunk so that we can increase our comprehension. And there's always a balance between, we want to use patient-friendly language, no jargon, no complicated terminology, but we also need to use the real proper terminology, not simplified euphemisms. We need to make sure that we're using the words that we need to use, but not overcomplicating it with extra jargon and complicated language. So again, all of these strategies are good for cognition and language. So cognition being, perhaps one of the dementias or Alzheimer's or something like that, or traumatic brain injury, or maybe a CVA, but also language if we've got aphasia after CVA, something like that. These work for both of those. Some things to avoid. I don't think many of us have intercoms in our offices, but that really does throw people off sometimes. So make sure that we're speaking face to face, in person. We don't want a disembodied voice all of a sudden coming into the room. If you are working with somebody who has one of the dementias, we want to avoid arguing. Arguing is a harsh word on here. It can be hard to convince. It's better to go with the flow, and gently acknowledge, oh, I understand. And then you can bring in distractions and move on to the new topics. You can't really reason very well sometimes with people with cognitive deficits that can really agitate them. So instead, you kind of have to play along and gently divert the subject if you're working with people kind of in those advanced stages. And again, I've said this again because it's so important. Don't talk about patients as if they aren't there. Address them directly. And lastly, you want to avoid too many providers at one time. That can be overwhelming. So this leads into a little bit more on language and just a little bit on speech. So in the SLP world, we split things up into receptive and expressive language. So for receptive language, that's understanding. See all of those suggestions that we just talked about under cognition. And just in general, think, I need to allow sufficient time for them to process. So slow down. Older adults, whether experiencing some kind of disease process or not, do experience a little bit of cognitive slowing and decreased working memory. And that can lead to longer language processing time. So going slow is crucial for comprehension. Expressive language in all adults as we age might be less efficient. We might use more words, more ambiguous words, trying to, we say circumlocute, people might say beat around the bush, trying to arrive at the topic. Your syntax and discourse. So discourse, so longer narrative storytelling. Your syntax meaning your word order, your sentence structure. You might see some changes there. It might be less cohesive when you're having conversations. But if you are noticing significant word finding difficulties, replacement of words, things like that, that may be indicative of something neurological going on. So again, that's when you refer to physician, refer to an SLP. We can check those things out, but allow sufficient time for them to answer. So for receptive, you need to allow sufficient wait time for them to process as you're talking. For expressive, you need to allow sufficient wait time for them to answer before you jump in again. I just put a little note on speech because what we know about speech as we age is that it does slow down a little bit. We might have less precise articulation. So again, think dentition changes. That can have an impact as well. Coordination. But if you're noticing anything significant, slurring, speeding up, those quick bursts of speech and little rushes, then we might be thinking something like Parkinson's, for example. I have a Parkinson's group that meets weekly here, a Parkinson's speech group on campus, free through grant. So if you have anybody, you can refer them my way if you're in the UND area, in the Grand Forks area. And we see that a lot, those blaming their partner, saying, well, they just can't hear. Well, possibly, but also you're speaking really rapidly in little short bursts of speech. So if you're noticing any types of significant changes, that's when we want to be doing a referral. So those were the main communication domains that change as we age. Let's talk about a few other things that we need to consider. And this is a big one. I'm assuming that most of you have learned and been thinking about this. Health literacy, that's really important. We may have some reduced health literacy due to the normal aging process, cognitive changes, or just due to the nature of technology changing and people not learning these skills. But we really need to be cognizant that more than 2/3 of our adults in the US over age 75 have below or basic health literacy right now. So that's why it's important to think about this, especially over age 65. they're at risk, and especially in the low SES population as well, at risk for low health literacy. And we all know that leads to poor outcomes. So what we can do, some of these are the same as we talked about in the cognitive and language section. Simplify your verbal communication with all of your patients, okay, with everybody. Use plain language. Don't overuse medical jargon, but still we want to use, the real terminology that needs to be used. Emphasize your key points and repeat and explain. It's a good idea to use open-ended questions. Instead of saying, do you have any questions? How often do you get no? I don't think so. But what if you said, what are your questions? Take a minute and think of a couple of questions for me. So that's my favorite go-to. What are your questions? Okay, tell me your thoughts instead of, do you have any thoughts? That's a closed question, yes or no. Okay, we want to use an open-ended question. Make sure you're writing down information. Again, you can use that teach back method at the end. One thing I think is really important is our access to our websites and our online portals. I'm pretty concerned about when we're at my clinic, for example, new client, they call and they're confused when the intake paperwork is emailed through, you'll get an email. It's going to come from a non-replyable email address. It's going to be in a liquid file because that protects confidentiality. You're going to have to download it. Well, if it's in PDF, you're going to have to open Adobe and then save it. That is difficult. That's not working. And it's a barrier. We can't be having these barriers for our folks. So I'll often just say, do you want me to mail you a paper copy? Do you want me to email it in the portal? Give them that choice. I don't make assumptions. I offer that to everybody. Another characteristic of communication we need to think about is underreporting. Our older adults are often less likely to report their symptoms, and they give more positive ratings to their health. I don't know if it's a generational thing and that'll change, but currently that's what we're seeing. So some things that we can do is ask direct questions about sensitive topics, because if you ask, do you have any concerns? Somebody might not want to bring them up. So you might have to ask very direct questions, sensitive things, incontinence, not being able to drive anymore, substance abuse, mental health, sexual health. You might need to just ask direct questions about that. Other clinicians like to use the some people approach. When some people cough or sneeze, they leak urine. Have you had this problem? Or many people your age experience a problem like this. Do you have, this problem or any concerns with this? So to mitigate that underreporting in the elder population, those are some strategies that you can use. And then the last other consideration that I want to talk about with communication is cultural humility. So on the SLP side, and I'm sure in some of your fields as well, we've really gone away from talking about cultural competence, because that implies that I learned this, I'm competent now. We're never competent. Our learning is continuous. So we like to use the word cultural humility. And I'm a teacher, so I teach students and train students here. So I often talk about this and how this is everyone's responsibility. It's your responsibility to be aware of the cultural terminology, the cultural customs. It's not their job to teach that to you. It's your job to be aware and make sure that you are being sensitive, acknowledging diversity, celebrating diversity, and adapting your healthcare to meet their needs socially, linguistically. This is really, really critical in reducing disparities among groups. Is taking the time to constantly be working toward our cultural knowledge. Lack of understanding and unwillingness to learn, that's going to result in errors, in healthcare errors, and lack of those good therapeutic communicative relationships, inaccurate evaluations, perhaps even diagnoses. So we need to be really alert of these things, and also about not making negative judgments about people based on our own assumptions. And I mean, there are lots of great resources out there to help us with this. Some of the main ones that we want to talk about is names. Make sure you're knowing how to pronounce people's names. Imagine how that makes you feel if somebody doesn't pronounce your name correctly. Are you going to really have a trusting relationship and feel that they care about you and then communicate what you need from your healthcare provider? Pronouns, that's another thing we talk a lot about. Something that a lot of people have gotten to doing is, I could introduce myself. Hi, I'm Jessica. I use she, her. Would you care to introduce yourself? We do try to get away from asking people in group settings, but sometimes even in your one-on-ones, what are your pronouns? Because sometimes a person might not want to share, and sometimes they might. So you can give that invitation. You can share yours if you'd like, and leave that open if they would like to share theirs. And if they do use different pronouns, then you may expect, make sure that you're respectful of that and using that on all the communications. Also culturally, think about facial expressions, physical contact, eye contact, and gestures. Those things are very different across the world and across different cultures, and can be really misinterpreted. So like I tell my students, it's your job to find out ahead of time some of these things and to be respectful. Okay, this is the last one I have for other topics about communication. Oftentimes we are in a situation where we're communicating with caregivers in the room too. And that's great. Caregivers, family members, they can be our allies in care. But again, address the patient directly. If you're working with an interpreter, same thing. Interpreters are hard to find, at least around here where I live. But we're addressing the client or the patient directly, not the interpreter. Caregiver observations have value. So that's great if they are involved in the care and they have permission to do that. You can be talking with them. What are your goals? But you have to determine if the patient wants to include that family member in their medical discussions. Maybe they only need to be there for part of it and not the whole time. Maybe there are sensitive topics where you'll want them to leave the room. So we do need to make sure that we are being respectful of that relationship, not making assumptions. When you walk in the room, you don't want to say, oh, is this your dad? When maybe it's not, maybe it's your spouse. So I like to say, oh, hi, introduce yourself. Are you two related? Let them tell you the relationship, if you're just meeting somebody for the first time. Although they are allies and we love to have them there and be advocates, we do have to be careful if our family members tend to speak for the older adults. The patient has the ultimate authority, until it's legally, given to someone else and they're brought into that relationship. The patient has the authority, so we need to be very respectful of that and be aware that they're not pressuring or helping try to make their family member give the right answer. This or that's easy. So when information is provided by someone else other than the patient, make sure that we verify it with the patient and really respect their autonomy. Okay, let's move on to just a couple of slides about some general strategies for effective communication. Some basics. These can be used with everybody. But with our older patients, sometimes you want to start by considering using their formal address unless asked otherwise. It depends upon your situation, but you might want to start with Mr. Smith or Mrs. Olson, and then, see, do you mind if I call you, John, something like that. Make sure we're not using those patronizing or condescending words such as dear or hun. We really want to be respectful. Older adults, they maintain their existing vocabulary unless there's some type of disease process going on. So we don't need to talk to them using elder speak or talking like a child. When communicating with anyone, active listening, that's the key. Okay, I see. Nodding your head. Oh, I hear you say, or it sounds like you're saying, or let me see if I can rephrase this. Is this what you meant? Those type of active listening things are really important. Another tip is that when medical information is framed in a positive manner, our elders are more likely to comply with the recommendations. It tends to work better if I were to say walking will have important, health benefits for your heart versus saying, if you don't do this, you're going to get cardiovascular disease. So try to frame things in a positive manner anytime that you can. Nonverbals. Make sure that we're aware of our nonverbal behavior. If you are documenting, in the moment, and I know this happens, we do this. We even talk about training our students to do, that in point, in session documentation. If your body is turned away and you're focusing on the computer, you're not focusing on your client and your patient. And that can speak a lot to them. That can say volume. So make sure that you are using good communication face-to-face with the individual as much as you can, and watch for those body language cues that appear to be significant for that patient. If it seems like, okay, they're listening and following along, or I think I'm losing them and they're shutting down. So I found this checklist from ASHA, American Speech Language Hearing Association. I think this is just a nice little checklist for ourselves to think about, the barriers that we may have and how can we reduce these barriers visually, auditorily, our written language. Are we using well-constructed plain language? Are we having good volume, natural intonation? What kind of nonverbals are you using? Are you giving that wait time so that they can listen and process? And are you offering them extra time for them to respond back and formulate what they're saying? Are you encouraging people and their caregivers to ask questions, open-ended, and offer comments? And hopefully now I've given you some ideas of when you can refer to a speech language pathologist. So, any questions about what I've talked about so far? Anybody have any ideas or comments? Anything to add? Nothing in the chat? I do have a couple.
Nothing in the chat.
All right, good. I must have explained it all. I do have a couple of scenarios. Let's take a few minutes, and I'd like you to jump in and share some ideas. So let's look at this one first. In an effort to reduce waste and streamline communication, your clinic is going paperless. And I think a lot of us have been there. They're transitioning to e-visit summaries in the online health portal and text appointment reminders in lieu of printed summaries and paper appointment cards. You're concerned that several of your elderly patients are not technology literate. What could we do? What ideas do you have for how you could advocate for your patients, or different options, or how can you help your patients navigate these challenges? And first of all, does anybody have any experience? Is this happening with anybody? Is anybody working in a clinic where you're going paperless? Or we use these types of portals and appointment reminders?
In the chat, we have you can ask the patient's preference and how they would like to receive the information.
Yep, that's a good one. That's what I do with mine, because I just know that a lot of them aren't going to be able to figure out the online portal. Okay. What else?
So let's see, we have ER patient a printout of visit to be mailed or given to them.
Mm-hmm.
And then ask for pointer cards to write down quick notes.
Mm-hmm. Yeah, I mean, I know when I have an appointment, I still like a little printout that I can stick on my calendar or put in my, somewhere. I like when you get those little sticker ones, especially that you can stick on the calendar. But I also very much appreciate my text email or my text visit reminders too. But we have to think a lot of our clients don't have a phone that texts, for one thing, or they wouldn't know how to use it and text, reply back yes or no. So appointment cards, I think that's an easy thing that you can do. One thing I really worry about are the portals where you're going on and making your own appointments, or the billing too. Like, oh, now we have paperless billing. That's not always easy, and they don't know how to go on and do a password reset and get in and set up the account and then go in and pay their bill. And then are they getting, bills backing up and things like that? And I know people in my life for whom
I was going to say, my daughter, who's 23, struggled with this morning. So
yeah, so these are some real concerns that we have. So I think it's a combination of being flexible, like you said, giving choices. And sometimes you have to sit down. Like, I have a patient right now who, like, give me your phone, get it out, let's put this in there right now, because they don't know how to do it themselves, and it's stressful. And the point of this is that's a barrier that is then going to discourage people from seeking the treatments that they need. And we want to reduce the barriers. Let's look at one more of these. Okay. Your patient Terry is accompanied by their partner Lynn for a follow-up. Terry's facial expressions indicate they're not comprehending the need for an upcoming procedure, and you don't think they're wearing their hearing aids. Terry didn't bring their medications and gave an off-topic answer when questioned about their dosage. Neither Lynn nor Terry recall being referred for a therapy appointment last visit, and neither know whether it was scheduled. And when you ask Terry about it, Lynn states Terry doesn't need to go to that. So what are our possible communication barriers that are going on here? Let's see if we can think of a few. They're not hearing the questions, not responding correctly. So definitely hearing is one of them. That's one of the areas we talked about today. Thank you. What else could be a barrier that's happening right now? Denial, need for therapy. Yeah. Someone speaking. Yep. Speaking for the partner. They're not clear if therapy is needed or not. So we have possibly hearing, possibly caregiver interference, even if they're meaning well. Could there be something cognitive going on, being that they weren't understanding what was happening? Okay. So this is very realistic. I feel like this has happened to us too. So some possible solutions would be all of the things that we talked about before. Writing things down, making sure they're understanding, visiting with the patient themselves to make sure that their partner is actually saying their true wishes, maybe some cognitive screening. We have to see what's going on here in this situation. So, okay, I think it's just about time for us to wrap up. So I do have just a wrap up for you with our learning objectives. Today we talked about several different things. So I'm hoping now that you understand what domains of communication may be affected by aging, and that you're also able to have a little bit better understanding of what could be typical aging changes and something that might be concerning and lead you to for a referral for some more assessment or evaluation. And hopefully today you gain some strategies to communicate more effectively with elders. So I did put our references on here, and I believe that you're all being sent the PDF of the slides if you're interested. And again, my email's on the first page. Does anybody have any questions about communication or about speech pathology or anything like that? I can hang on a few minutes. And I see that your host test is also up in the chat as well.
Yeah, so any last minute questions for Jessica? We did have a question. Are we talking to the person or the caregiver?
I always recommend talking to the person, even if you know that they're not really understanding. I like to position myself where I'm talking to both of them when we're in some of the advanced stages, and talking to the person as much as possible, but knowing that the caregivers, depending upon the situation, might be doing more more the answering, but definitely when the individual themselves is able to, we direct our communication right to the person. That's a good question.